All right, so it's 8:01, always the time I start. So I want to thank everyone for coming to Grand Rounds. Again, I think it's a privilege to hear such great speakers, and I'm very appreciative of your time that you spend to come here. And I'm going to hold off on my meteorological report because I have a few things to say about the chair search. I want to remind everyone our chair searches have begun. Our first candidate, Dr. John Bird, is doing his academic seminar today, if you didn't get to go to the town hall meeting yesterday, and that is 12 to 1 in 1325 in HSLC, and he's talking on targeted therapy for leukemia. People are going to be coming in very quick succession. Next week on Thursday and Friday, March 7th and 8th, our next candidate is coming. That's Dr. Monica Kraft. She's the chair at Arizona of Medicine, and she is a pulmonary critical care doc. And when anybody comes in, if you see them coming in, the first day from 5 to 6 p.m., that's when their town hall is going to be. And that's the best way to just get an idea of who they are as a person. They'll talk for 20 minutes, and then they'll feel free to answer questions. So the more of you that can come, the better. So many of you came yesterday that we're going to change the room so that it isn't standing room only, but thank you for that. I was petrified that no one would show up. So, with that, we have a fantastic Grand Rounds today, and I want to welcome Dr. Elaine Pelley. She is one of our faculty members here. She is an associate professor on CHS track. She's going to be talking about when a specialty becomes women's work. Occupational gender segregation in medicine, which I think is going to be absolutely incredible. She's in the Division of Endocrinology, Diabetes, and Metabolism, and a little bit about Dr. Pelley. So she did her medical degree at Loma Linda University in Loma Linda, California. She did her residency and internship at Beth Israel Deaconess Medical Center, Harvard Medical University in Boston, and this was followed by her fellowship in diabetes, endocrine, and metabolism in Rhode Island at Brown Medical School. She joined us right after graduating from her fellowship in 2006, and she does hold a leadership position now as the Director of Preclinical Medical Education for our Phase 1 Forward Curriculum. I think the honor that I wanted to highlight for her was that in 2015 she received the coveted UW School of Medicine and Public Health Dean's Teaching Award, which is actually just fantastic. And when I asked her what she loves to do, it totally fits into her leadership role. She loves to design curriculum, which I think is great. So Dr. Pelley, please come up and start your Grand Rounds.
Good morning, everybody. Thanks for being here, and thanks for the invitation to speak. And I'd like to thank the colleagues of mine who have covered my clinical loves, osteoporosis in a previous Grand Rounds and primary parathyroidism, leaving me sort of open to go a little off book with this. And I find this topic really fascinating, and I hope you do too. I have nothing to disclose about this, except that I'm a female physician and an endocrinologist, which will probably be obvious why that's relevant. So this talk, though I didn't know it, probably dates back to the late 1990s when I was a medical student, and I remember telling a faculty member that I was interested in endocrine because I love feedback loops. I love feedback loops. And so the response really took me by surprise. They said to me, oh, endocrinology is a very popular specialty for women. And this was sort of a moment in my life because it was the first time it ever struck me that my gender should play any role whatsoever in my specialty choice, or that anyone would think that it might. But it wasn't an unfounded comment. I mean, that faculty member was technically correct. Endocrinology is on track to be the most female predominant specialty of internal medicine. And the female share has gradually increased to our current level of 70% female fellows. So why is there such an influx of women into endocrinology? I think that's a really good question. I'm going to have you hold it, and we're going to get back to it at the end. So my questions that I had when I decided to do this talk, and I didn't actually know the answers to all these questions, which made creating this talk really fun, is what is the status and trends of specialty gender segregation in medicine? And when we think about gender bias in medicine, which I think is getting more press recently, should we continue to think about it mainly in terms of the implications for female physicians? Or is there any value to thinking about it in terms of the implication for the specialties in which females are at this point, overrepresented? And then what can we learn from sort of more general US workforce data that might help inform our transition as more women are entering medicine? So my learning objectives, written in outcomes-based language for those of us that love that sort of thing. And we'll move on to look at sort of broader workforce data. So it turns out that occupational gender segregation is an extremely prominent feature of the US workforce. As of 2012 data, 44% of US male men worked in male-dominant occupations, meaning that more than 75% of the workers in occupation were male, whereas only 6% of women worked in those occupations. And the inverse is also true. 40% of US women work in occupations where more than 75% of the workers are female, whereas only 5% of men work in those occupations. So this has been studied in sort of social science literature, and there is a statistical measure of segregation called the index of dissimilarity. It ranges from 0, being a fully segregated, fully integrated, I'm sorry, that's opposite, to 1, which is fully segregated. We'll look at a lot of graphs about this. So this looks at the workforce as a whole. So here you go. This is data from 1972 to 2009, and you can see that the segregation has generally declined as women entered the workforce, has generally declined. But what's interesting, what this arrow is pointing at, is the mid-1990s, when progress completely stalled in this. So from the mid-1990s to today, there really hasn't been any further integration of the workforce in terms of gender. And people often say, well, we're just not there yet. You know, tincture of time, we'll get there. And so looking at this graphic, it breaks down segregation by age. And certainly older age groups have been historically more segregated and younger age groups more integrated, as we would have expected and hoped. But if you look at this younger age group, it's actually starting to tip upwards now, such that currently the younger age groups are converging with the older age groups. And so that is probably contributing to why we've sort of stalled in our progress in this. So since the workforce as a whole was originally mostly male, integration required women to enter previously male-dominant occupations. There was just no other way to do it. Women had to enter occupations where they were nearly all men. And it's been observed, though, if you look back on this, that once a formerly all-male occupation experiences a substantial influx in women, that occupation quickly becomes all-female. And that there's really no cases where this process has happened in reverse. Examples of male-to-female occupations are bank tellers, secretaries, teachers. And so a study of looking at U.S. workforce data over a century, so 1900 to 2000, showed that as women enter, occupations exhibited an abrupt decline in male employment participation, a phenomenon known as tipping. And this can actually be measured, and when they looked at the occupations, they found that there was a tipping point of about 25 to 40% female, where men start to exit that occupation, and that the tipping points were lower for blue-collar occupations. So this is showing it in graphical form. So you can see this line is the same on each graph. This is the full workforce, the gender makeup of the full workforce. This is the male share. So the workforce was mostly male, and then women gradually entered, sort of coming to a steady state around 50%. That yellow line is the 50% mark. And what I want you to notice about this is, number one, you know something about the stage of life I'm in, because this looks like water slides to me. Bam! I have small children. And so there are very steep curves that you can see here, although this is 100 years, so it takes a long time. So at any given time, it probably didn't feel like this was happening, but when you look back over 100 years, it clearly was. And the main thing I think it's important to notice here is that this drop starts long before the 50% mark. So, you're talking, the tipping starts sort of in that 25 to 35% range for many of these occupations. So why do occupations tip? And there's a really nice article that I referenced for this talk from 2015 that looked at a bunch of different theories to try to see if the data fit. And the one they concluded that fit best was this Schelling theory or prejudice theory, which basically says that substantial segregation can result even from very weak prejudice against a group. And this can occur even when both groups prefer integration, because the impulse to avoid minority status overrides this. And this was in part concluded to be likely the explanation because they found that tipping points for occupations were lower in geographic areas where men scored more highly on scales of sexism. So that data is from the workforce as a whole, but I think we would like to imagine that we might have unique characteristics. So stepping a little closer to medicine, people have looked at this in academia. So there was a study of doctoral degree recipients from 1970 to 2002. And during that time, the degree recipients increased from 14% of the doctoral degrees being awarded to women to 46%. So a really big increase in female representation in doctoral degree recipients. But this line here is the measure of segregation during that time. Really no change over all 40 years, despite this large influx of women into the arena. So these authors also found that their data showed evidence of tipping as well, and the tipping point of men earning a given degree occurred at about 25% female share. And they concluded that consistent with that Schelling's tipping model, above a certain percentage of women, men are deterred from entering fields by that field's further feminization. And I think very interestingly, feminization of a field even eventually deterred women from entering that field at a tipping point that was slightly higher. I think this is important because a lot of the research in gender bias in the workforce shows that sexism is not a male thing, sexism is a human thing. And so a lot of the gender bias studies will find that women also carry these biases. All right. So now we have to move on to a slightly different topic that I think will become clear why it's related. And we have to talk about the gender pay gap. So this is the graph that if you want to get in a fight with strangers on the internet, the best thing to do is to post this image. Because people don't like it. And I guess I feel kind of good about that because I think people don't like it because they don't want it to be true. And I take some solace in the fact that I think people don't want this to be true. But the reality is it is true. And it is one of the interesting problems that we seem to think if it's explained, it's no longer a problem. And there's lots of problems we have in society that have explanations that are still a problem. And I think this also is one of those. But if you get into a fight with somebody on the internet about this, which I will not own up to having ever done, you will get the yes, but response. Yes, but women work in lower paid occupations. Women work fewer hours, even those who work full time. Women have less human capital, basically due to parental leaves and other time out of the workforce. Women prioritize other factors over salary, or my all-time favorite, women don't ask. There is some underlying truth to all of these. There's some kernel of truth that is at least worth discussing, which we can't get to them all today, but I think it's really important for our discussion today to talk about the first one. So it is true that women work in lower paid occupations. These are the 25 highest paying occupations in the US workforce and the 25 lowest paying occupations. And you can see that this line represents if sort of gender was equal, if people were equally distributed. And you can see the green lines infringing pretty far into the purple side of the high-paying occupations. So the males are overrepresented in the highest paid occupations. And the purple lines infringing on the green side in the lowest paid occupations. So women are very markedly overrepresented in the lowest paid occupations as a rule. So here's a quote from a really, I think, valuable report that's out there that I have referenced for you if you're interested in. Men are paid more for watching cars as parking lot attendants than women are paid for watching children as child care workers. I think few of us would argue that the former is intrinsically more valuable work. So why are women clustered in low-paid occupations? And there's research on this that I will show you, and I think it's nice to know that they started from the presumption that women are reasonable actors, and so they're not just flocking to low-paid occupations because they're low-paid occupations. They wanted to find some reasonable reason why this would happen. And there are three main theories that I want to become familiar with because we want to look at them a couple times today. So firstly, there's a theory of equalizing differentials. What does that mean? That means that women self-select into jobs that require less human capital investment due to having other priorities. And that these jobs appropriately have lower wages. So if this is true, our data should show that if we control for educational and skill requirements, there would no longer be a relationship between wages and the gender composition of that occupation. The second theory that's out there is called queuing, which basically talks about employer hiring discrimination. So if you imagine that employers in general prefer men, then men will compete better for the higher paying jobs, leaving the lower paying jobs for the women. So women would be sort of differentially shuttled into low paid occupations due to hiring practices. And so if that was true, you would think that the wages of an occupation at time point A would predict the gender population at a later time point B. The third potential explanation is called devaluation. And that basically is a theory that work done by women is systematically devalued over time. So it's important to note this theory makes no claim as to why women end up clustered in the job, whether it's the women's preference or even if the hiring practice caused it, but that once they are there, the wages of that occupation go down. So if this were true, we would see that the gender composition at time point A would statistically predict the wages at later time point B. It's the opposite of queuing. So what about equalizing differentials? Really, the answer to this is no. There is still a gender wage gap, even when you control for all those work factors that you imagine women might be choosing because of their alternate preferences. I think this is interesting data here, looking at the weekly earnings of low skill, medium skill, and high skill occupations that are either mostly male, mostly female, or a mixed composition. And what you can see is that at every skill level, the female-dominant occupations makes significantly less than the male-dominant occupations. And what's really interesting is that the negative relationship between the presence of women in the occupation and its earnings is strongest at high-skilled occupations. And that sort of extrapolation analysis predicts that a 100% female high-skilled occupation would earn 54% of what a 100% male high-skilled occupation would earn. So probably not equalizing differentials. But is it queuing or devaluation? And this is a sort of a chicken and egg thing. We can't really answer this question with cross-sectional data because we need to know what came first. So fortunately, in 2009, someone did this study and analyzed U.S. Census data across all the occupations from 1950 to 2000. So they looked at 50 years. And they did find some very early evidence of queuing, which is to say hiring discrimination against women, right in the 1950s. But that was gone by 1960. But in every decade, the previous gender makeup predicted the later hourly wages every time they looked, with a 0.5% to 5% decrease in hourly wage per each 10% more women in that occupation. So looking at longitudinal data actually most strongly supports the conclusion that the occupations that become female predominant become lower paid because the workers are women. And on top of that, I think as most of us know, men earn more than women for full-time work in the vast majority of occupations, 107 of 114 in the US Census information. So here it is by hourly earnings. So if you look at this, it's a lot of data, and there's lots of fun things to look at. But basically, we're looking at a graphic where we have low-skilled occupations again, medium-skilled occupations, and high-skilled occupations, and there are definitions of how they made these differentiations. And then occupations that are mostly women, greater than 75, somewhere between 25 and 75, and then greater than 75 male. And then what the hourly wages are. So this gets rid of the question about whether women are working fewer hours to explain this. And what you can see in red is the pay gap in each of those areas, which is what the difference between the male and female salaries, which with a pretty substantial pay gap, hourly pay gap in all of these, except for, interestingly, female predominant high skill occupations, although the theory for that is that the women in those occupations usually have much, much more seniority, think librarians or other very female predominant occupations, and so probably the pay gap is getting hidden by the differential of experience there. But that there's a pay gap in most of them. which is interesting. But the thing that I really want to look at over here is the pay gap between the female occupations and the male occupations for those work of the same skill level. So the first thing to notice about this is if you are looking to have a higher hourly wages, the first and most important thing you should do is gain more skill. This is true for both genders. Definitely people gain hourly earnings when they gain more skill. And you can at least double your salary by doing that. The next most important thing to do, interestingly, is to work with more men. So pick an occupation in which most of the workers are male, which is difficult for all women to do because, it would then no longer be a male predominant occupation. But there's actually quite a lot of value in moving rightward on here in working in occupations where there are a lot of men. And you can raise your salary, at least at the high skill range, by about 50% by doing that. And then thirdly, if you have the choice, you could choose to be male. And honestly, that's just like the cherry on top. That's actually the smallest increment improvement you can get of these things, but it's a little bit. So that I found pretty interesting, that the relative benefit of these different changes. The other thing that I think is really kind of worth really focusing on this is that of all the pay gaps on here, the red, which is the male to female pay gap within those occupations, or the purple, which is the pay gap between occupations that are mostly women and occupations that are mostly men, the biggest gender-based pay gap on here is the one faced by men who choose to become highly skilled and then choose female occupations. That's a one-third pay cut that they're taking to do that on average. So no one ever thinks about the gender-based pay gap that's affecting men, but it's the biggest one on this table. All right. So that is, I think, some pretty good background for us to move into medicine, which is, as I promised, what we were going to talk about today. And so when we talk about gender integration in medicine, this is the happiest slide we have to show. This is the one we'd like to say. We like to say, look, we've been working on this for decades, but look, as of 2007 or so, we're done. We're really close to 50-50. This looks like it's diverging, but it's actually not. Women entrance to medical schools in 2017 actually were a little bit higher than men for the first time. So we're doing pretty well at getting 50-50 mix at the medical student level. But how integrated are we really? So once we have that funnel of having 50-50 men and women in medical school, what happens to them then? And this is data from the AAMC most recently, so this reflects 2017. And there is a wide range of gender mix amongst specialties, all the way from pediatrics, which is 63% women, down to, and I bet you thought it was higher. Anybody going to admit you thought it was higher? Yes. OBGYN, only 57. I still have to relook at that because in my mind, it's higher than that, which I think is interesting, how many women it takes for us in our minds to imagine that it's more of them. And then orthopedics is down at 5% women. So is our future more integrated? Because again, I think there's a lot of talk that, oh, we're just not there yet. Time, just give it time. It's going to get better. And it's conceivable, but if you look at this graph, which is basically when I mapped that same data of pediatrics down to orthopedic surgery and the current practicing physicians, and then I mapped the gender fractions of current fellowship programs. So everything's higher, of course. There's more women in medicine, but it really looks like the fraction of trainees in any specialty roughly parallels the fraction of practicing physicians in that specialties, just more of them. But we're not flattening this curve. It's not like women are stopping going in here because we've hit 50% and now filling in over here. That's not happening. This line is just going up. This sort of gestalt made me ask a question. There's me. You can see a picture of me asking a question. So my question was, what is the index of dissimilarity in medical specialties, and how has it changed over time? And I was hoping that someone else had done this work for me, but they had not. So good fortune for you, I did this. And so this is data no one's seen, which I think is kind of exciting. So This, just to give you background, is the fraction of female physicians at different time points, as far back as I could track, which is 1970. The AMA, the green data is from the AMA, and they have data from 1970 to 2011. And then the blue data is from the AAMC, but you can see it's pretty much looking at the same thing. So I merged these two data sets. And then this last line is the big jump represents our trainees as sort of, I thought, a proxy for what does the future look like. And so once I had that out, I did the index of dissimilarity at every one of these years for the gender makeup of all the various specialties. And I saw this. So the increase in female share from 8% to 12% in the 1970s does look like it was associated with some decline in segregation. But we've had no further progress since 1980 on this, despite the female share increasing from 12% to 35%. In fact, the gender segregation of our 2017 trainees, which are 46% female, is really, 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 really similar to the gender segregation of the entire physician workforce in 1980. This actually kind of surprised me when I did this. I thought for a while I was doing it wrong because I kept getting the same number. With every data set I looked at, the number was basically identical. But this is what we have. All right, so we're seeing some things in the physician workforce that we had already kind of seen in the workforce as a whole. Sort of this stalling of gender integration. In fact, we stalled much earlier than the workforce did. So then I wondered, well, do specialties tip? You know, all these occupations that tipped, do specialties tipped? Or more specifically, is there any data that increased women entering a specialty deters men from entering that specialty? And one thing we have to remember is we don't yet have any medical specialties that actually meet the threshold of a female-dominant occupation. We're not there yet. So the best we can do is look at our two most female prominent specialties, which is pediatrics, again at 63%, and OBGYN at 57%. So this I'm just going to ask you to do your visual look and see if you think this has tipped, but this is the AMA data and the AAMC data, and you can see that male OBGYN grow and then stopped in the 90s at about 22% female, and then the male OBGYN started to decline. These are raw numbers of physicians, where the female line just keeps going up. And then pediatrics, which looks fairly similar, different numbers, but the male line was climbing and then stopped actually right when they hit about 50-50, and then started to fall, where the female numbers continue to climb. So certainly looks like some similar evidence for male, the increased fraction of women representing raw numbers of fewer men entering the specialty, despite overall numbers of physician growth. So, with the ongoing gender segregation, and at least this clue that specialties could tip, I think it's super important that we start being cognizant of the pending challenges that female predominance might carry for a specialty. And there are a plethora of areas we could talk about, which we don't have time for today, but if anyone's interested, I have a paper on this that you could explore in your spare time, and has some really great references if you wanted to look into this more, where my co-authors and I looked at gender differences in professional satisfaction and burnout, which is been shown a lot of places, including here locally, to be worse for female physicians. Issues of work-life balance. One of the tidbits that always sticks with me when I looked into that is that one study looked at divorce rates amongst physicians, and they found that longer work hours correlated with divorce only if the physician was female. The motherhood penalty and the fatherhood bonus, which would be a whole different talk and is deeply intriguing. The gender gap in academic leadership and academic advancement, which I think is getting more and more press, and a lot of people care about this and are working on this. And then something that doesn't get much press, but is also very interesting, is the gender-based expectations in the patient-physician relationship. There is really good research out there that patients expect different things from male and female physicians. They are simply not playing the same game. One, again, tidbit to maybe teaser, if you want to look into this more. One study looked at at nonverbal actions of a physician in the exam room. So not what they said, but various things that they did, and how that impacted patient satisfaction. And there were things that increased patient satisfaction if the physician was one gender, and decreased patient satisfaction if the physician was the other gender. And the one that really got to me was looking at the patient chart. If a male physician looks at the patient chart in the room with you, that increases patient satisfaction. But if a female physician looks at the patient chart while they're in the room with you, that decreases patient satisfaction. Crazy stuff. But it's out there, and it's very interesting. But for the purposes of this talk, we are going to focus on the pay gap. So, the gender pay gap in medicine. One article I read estimated it's $19.5 billion a year is the total amount that U.S. female physicians stand to gain from pay equity. It's a lot of money. So the pay gap in medicine, like in all occupations, can be explained in various ways. So one, it can be explained by work factors. What do we mean by work factors? Well, work hours, how many patients seen, do you do procedures, what kind of procedures you do, are you employed or self-employed, what geography you work in, like lots of work factors that can be looked at and controlled for, but do explain differences in pay. So a specialty is sort of a work factor, but because of the focus of this talk, I sort of broke it out. So differences in female and male physician pay that is explained by salary. And then there's a chunk that is unexplained, which then is attributable to bias. I think it's important to remember that even the portion that can be explained has negative consequences for the financial well-being of female physicians. So you think about female physicians don't pay less for medical school. They don't have less medical student debt. They also need to retire. They also have kids that need to go to college. Their eligibility for often things like life insurance and disability insurance hinges on their salaries. So there are consequences to this, even for gaps that can be explained. But there is an unexplained pay gap. A lot of people hope that there isn't, which again I take as a good news that people wish that this didn't exist. But people have looked at this, and they've looked at it quite a lot of times. So I have just 7 references here that have looked at it over the last almost 20 years. And they try to adjust for all those work factors and for specialty. And they end up with this unexplained gap. So this first one had a 14% gap after adjusting for those factors. Another study had about 12,000 gap. This was on academic physicians. Interestingly, it worsened by $500 per year of women's seniority, so women lose ground over time. This 2006 study I think is particularly disturbing. It was done just in general internal medicine, so avoided the whole specialty factor altogether. And found that the adjusted pay gap was $36,000 a year for white females, but $56,000 a year for black females. I think this is not the focus of today's talk deserves at least a second here of saying that there's good data that all of these things I'm talking about are a double whammy for women of color. And here is, I think, a really good example of that. The white bar is the male salary, the gray part is the part explained by work factors, and the black part is the unexplained. So you can see that it's actually that unexplained pay gap that gets bigger and bigger as you move from white male to black male to white female to black female, and that it's quite large. There was another one that looked at primary care physicians, showing the gap of about 20% and that it didn't appear to be narrowing over time. An interesting study in 2011 looking at the salaries of physicians in their first job out of residency. So just graduated from residency, got their first job. And despite controlling for all those things that they could think of to control for, they found a $17,000 pay gap between male and female residency graduates. A 2012 study looked at physician researchers and showed a pay gap of about $12,000 after controlling for everything they could think of. And then a 2016 study of over 10,000 academic physicians at a bunch of institutions across the country showed a pay gap of about $20,000 after adjusting for age, experience, rank, specialty publications, NIH funding, clinical productivity, really all the data they could get their hands on. So it does seem that if we want to be evidence-based, as we want to be, that we have to accept that it does look like there is still, as much as we don't want there to be, a unexplained pay gap in medicine. But I am really kind of interested in this question of whether the pay gap that's explained by specialty is justified. So this is again, the percent female of our different specialties, going from pediatrics all the way down to orthopedic surgery, the same line that we looked at before. And this is a salary data set that actually got, the internet is helpful. I actually got from Doximity, which is trying to get into the pay transparency world, and they have a lot of salary data there. So these are the Doximity salaries from 2015. And you can see, as I think you probably would have guessed, that there is a statistically significant inverse relationship between the number of women in a specialty and that specialty's salary. But if, like it does in the workforce as a whole, devaluation explains even a part of these lower salaries of the female predominant specialties, then all of the studies that control for specialty, which is all of those studies I just showed you, are masking the impact of gender bias on salary. So we circle back to our same theories and see what data we can have in medicine to see if any of these theories apply. So remember, these are our three theories as to why women are clustered in lower paid occupations. In this case, why are women clustered in lower paid specialties? Equalizing differentials, queuing, and devaluation. So, is it equalizing differentials? Do women self-select into specialties that require less human capital investment due to having other priorities, or have or trying to find occupations that have better schedules, or whatever the other motivator might be that make them prioritize wages less? There's not a lot of objective data on this, but there's some anecdotal data thing to think about on this. Probably not. For one thing, there are specialties that are rather glibly called the lifestyle specialties, which is probably a bit insulting, but it's definitely a term that's used by medical students and people who think about this, that are well known for their predictable hours and schedules, and women do not have any outsized representation in those specialties. Those are things like emergency medicine, dermatology, ophtho, anesthesia, this type of thing. So women don't have an outsized representation in specialties that are known for things that we might imagine women would be selecting specialties for. It also wouldn't explain it if they did, because these are not the lowest paid specialties. Secondly, OBGYN, which is our second most prominent specialty for women, is notorious and has been notorious for a long time, for long and unpredictable hours. So it doesn't seem likely that that explains it. So that leaves us potentially with exploring queuing and devaluation. And again, we need to look at data over time to sort these things out, because we don't know which came first. So we want to ask the question, did women originally disproportionately enter low-paying specialties? Presumably they would have, and potentially that would have been done due to women not competing well early on as women entered medicine, and they didn't compete as well for the higher-paying specialties. Or does increasing female share of a specialty lead to lower wages? So I wish that someone else had done this as well, but this really has not been looked at in medicine. But I will show you what I was able to put together. So, did women disproportionately select the lowest paying specialties in the first place? And that explains why they're in them now. So this is the oldest data I have, where I have salary and I have female share, which is 1975. I found a very helpful paper that was very interested in the changes in salaries between the mid-1970s and the mid-1980s, which has been helpful for answering our question. So this is the salary by specialty of these 5 specialties. That's all they had in 1975. So general practice family medicine, pediatrics, internal medicine, general surgery, and OBGYN. So OBGYN was actually the highest paid specialty of these in 1975. The other thing to note is they weren't very different. So low to high is about a 40% difference, which is no longer the case. So if women were differentially, due to hiring bias or selection bias, selected in lower paid specialties, you would expect to see that the highest portion of women here and the lowest proportion of women here, right? I mean, that would make sense if this theory was correct. But it actually looks like this. So women were about 5% of family practice, 23% of peds, 8% of medicine, 2% of surgery, and 8% of OBGYN. I think this data argues pretty well against the idea that women were systematically funneled into the lowest paid specialties early on. There really doesn't seem to be much correlation at all here. I think women appear, and I take this as good news too, appear to have selected what they wanted to do, which is nice. So that leaves us with devaluation, which again was our answer last time, as much as we didn't like it. So the question is, do salary trends over time differ between female predominant specialties and male predominant specialties? This is even harder to answer than the last question. And it's because getting reliable over time salary data, at least freely available to me, is not that easy. But I had those 2 data points, 1975 and 1985, for at least a reasonable number of specialties. And then I have current data from various online sources. So what I decided to do, just to kind of start to answer this question, is use those 3 data sets, 1975, 1985, and current. So this is the data for our 2 ends of the spectrum, orthopedics and pediatrics. So you can see here that I don't have 1975 for ortho. We didn't get that till 1980. But in the mid-1980s, orthopedic surgery was 2% female, and they earned about 1.5 times the median physician salary. And now they're 5% female and earn 1.6% of the median physician salary. So they certainly have held their value, if not gained a little bit, with these particular data sets. Pediatrics, on the other hand, in the mid-1970s, pediatrics wasn't bad. You earned 93% of the median physician salary in 1970. When they were 23% female. By the time they were 35% female in the mid-80s, it had dropped to 0.84 of the median physician salary. By 2017, when it's 63, we're down to about 30% less than the median physician salary. It's a clear decline. And I think most of you are thinking what I thought was, this is all because of the outside relative value given to procedures, right? I mean, these are very different jobs, orthopedics and pediatrics. So I think it's fair to ask that question. Maybe that's what's causing this. But so I thought, well, how can I answer that? And one way I realized I could answer that, or start to answer that, is moving in a little bit. So if I move in a little from the female side, I go from pediatrics to OBGYN. And if I move in a little bit from orthopedics, I get urology. So I thought, I think OBGYN and urology are a lot more similar in terms of sort of their practice makeup than these 2. And I was interested to see what the pattern looked like there. And I will share it with you. It looks like this. So in the mid-1980s, on this salary set, urology is 1% female and made about 1.23 the median salary, so about 25-ish%. And that's exactly what they make now as well. They're about 25% above the median physician salary, and the percent women is 9%. In the mid-1970s and the mid-1980s, OBGYN made about 20 to 25% more than the median salary. And when they were 8% and 18%, but now that they're 57%, it is an average earning. It's right at the average, almost exactly. So I thought that was certainly worthy of consideration, that this may be a real finding. And what I'd say is that if pediatricians and OBGYNs earn the same fraction of the median physician salary now that they earned in the 1970s, that's a $61,000 to $66,000 a year gap. This dwarfs the estimated unexplained pay gap, in most cases several times over. So not only, if this is true, not only is controlling for specialty underestimating the gender-based pay gap, it's underestimating it by lots and lots and lots. So I hope that somehow, some way, we can get a hold of better salary data and do this with some more reliable sources and see if it pans out, because I think it's pretty alarming. What about us? So what about internal medicine? As you would imagine, we're sort of a microcosm of the whole thing. We have a pretty wide spread. Interestingly, I don't know if there are any allergy and immunologists in the audience, but you beat us out this year for having the most women trainees, us meaning endocrine, who have been at the top for several years now. And we go down from there. And I highlighted in purple these 5 because these are all the specialties that are at least 50% female, which means clearly overrepresented from the number overall. And I didn't have to do the analysis of whether salary correlates with those numbers I just showed you, because someone had already done that for me. So Halverson did a study in 2010 and found, as I think would be no surprise to anyone, a significant inverse relationship between salary and the percent female amongst all the medical specialties, with sort of geriatrics, general internal medicine, endocrine, rheumatology down here with the highest percent female, which are the same specialties I just highlighted before. All right. So I don't know that I really answered the question of why do men and women choose the specialties they do, and that's because it's really hard to figure out human motivations. But devaluation theory doesn't make any claim as to why the gender segregation happened, only that it later led to the salary effects. So it is true, when people have looked, that gender-based differences in specialty choice are seen in early medical students, even as early as first-year medical students, and they do persist throughout training. The best data we have that I think is relevant to us is a study that was done 10 years ago now, and they did a survey of 15,000 PGY3 internal medicine residents. They had them take these surveys over a couple of years when they took the ITE, the in-training exam. And they asked about factors that they considered important in their specialty selection. And then the only statistically significant difference between male and female respondents when they looked at what those people rated as most important were these. So women were more likely to rate as very high importance desire to provide a needed service, long-term relationship with patients, the specialty of their mentor, time for non-work activities, and time with family. And to be clear, both genders marked financial considerations quite low, but still there was a statistically significant rate of men marking that as being very high, more than women. And this is even with self-report, where that might have been, so there might have been some restraint in reporting to the degree into which you were considering that, but they still found that significant difference. All right, so back to endocrinology. I asked you to hold that thought. So why has there been such an influx of women in endocrinology? And the answer to this is actually really simple. The answer is there hasn't. So these are the endocrinology applicants by gender since ERIS started, which is as far back as we have data. So going back from 2007 to the present, and we have had 14% decline in female applicants since 2007, but our ratio is up because the male applicants have declined by about 40%. Personally, I think this is a specialty in crisis. I don't think that we can have this obvious a decline in interest in a specialty and not expect it to have public health consequences. So I would like to get the word out on this because I think it's super important. So I'll wrap up here with saying sort of what do we know? We know specialty gender segregation is prominent and it is not dissipating. We have made no progress on this in 40 years. We also know that equilibrium 50-50 gender balance is unlikely in any occupation. We just haven't, as humans, figured out how to do that. And so if we do, we will be the first. And we seem to be a lot like the workforce as a whole in other ways. So I think it's worth thinking about that the possibility is that specialties with 50% or more female trainees may already be tipping. And we need to remember tipping results from the exit of men from a field more than an influx of women, which cannot be a good thing. And tipping appears to be associated with unfavorable salary trends and with an overall decline in interest in that occupation by both genders. 5 of our 13 internal medicine subspecialties currently meet that 50% threshold. And these are specialties where physician shortages currently exist and access to care is already an issue. I'm actually hoping that the next time anyone in this room thinks, why is it so hard to get my patient into endocrine? That they will reflect back on this talk, because when people ask me that question, this is what I want to tell them. Why do we care? I think we have to care because the future success or lack of success of an increasing number of specialties, including in our department, now hinge on the success of female physicians. I think we need to make clear, loud and clear, that men in those specialties have to recognize that they too have personal stakes in advocating for gender equity for the sake of the specialty, if not for the sake of their female colleagues. And they need to raise their voices in support. And I would like to believe, and I have reason to believe, that we are the type of community that cares about how each other are doing in terms of specialties, and particularly that our patients can get the care they need. And so I would like to encourage all of us to think more about this and what it means for our patients and the future care of our patients. So that is where I will wrap up. I would like to give a little bit of quick credit to all the work that was done by other people that I presented today, particularly work coming out of the American Association of University Women and the Institute for Women's Policy Research. I have links on here if anyone likes it. They do wonderful work promoting these issues, and as well as all of these great researchers across the country who have built all this great data that I was able to share with you today. So thank you.
From the audience. Go ahead.
Yes. On international medical graduates, I don't know that I've seen anything about it changing the balance of gender. I think what I've seen, they seem to follow similarly. Although there are increases in international graduates in fellowship programs that have a decline in interest in U.S. grads. I mean, you can see that in our ARIS applications and in our admissions. And so as people become less interested in some of these specialties, there actually may make room for more of our great international grads to get into these programs. Yes?
That was fabulous. Thank you. You might also be, there was a study where transgender people who went from male to female in the subsequent years made less, and transgender people who went from female to male in the subsequent years.
I'd perfectly heard about that. That's deeply intriguing. Dawn, yes. Mm-hmm. Right. Yeah, I think that's a fair question. Oh, yes, sorry. Right. Do we undervalue the care of women and children, and therefore that's manifesting in the salaries of the specialties that do that? It's certainly plausible. I think that one thing that argues against that is that when all the physicians were male, OBGYNs and urologists earned the same. So it seems not to necessarily have always been true. If it's true now, it didn't start out that way, it doesn't look like. Yes? The question is, why can't we fix the problem today? Why can't we raise the salaries of women in female-predominant specialties right now? And I will defer that question to others, but I think you made a point that shouldn't be controversial. There is really no reason, there's no law of physics that says taking care of endocrine conditions is so much less valuable to the profession than taking care of disorders that are higher valued. Yes?
That was wonderful. I'm curious about social constructs in our mind and social engineering. We construct
I don't know the answer to that,
Okay,
but it's...
you got to try to summarize.
Yes. The question is, let me is how much have we sort of created the, what I would phrase the illusion of prestige in our minds by some specialties being sort of putting more caps over time with how many they let in, kind of creating a supply-demand issue versus specialties that have focused on bringing enough people in to provide the care that's needed, such as pediatrics might have done. And I don't know the answer to that, but I do think that a lot of the forces that I talked about here are absolutely social constructs. There's nothing underlying it other than what we've decided to perceive things as. Yes, in the back?
Sitting in oncology just at the edge of the tipping point. Is there anything that's been shown to ameliorate tipping or things like that in any sort of specialty or in any field that you know of? Because, it seems like maybe that would at least be something that could provide some degree of help.
Right. So the question is, has anything been shown to kind of ward off tipping? The answer is no, although I think that one thing is that we don't want to be perceived as thinking that having lots of women in a field is a bad thing, because it objectively isn't a bad thing. I think we're all in agreement that women are great physicians and take great care of patients. That's not really in debate by anyone. But until we live in a world without gender bias, we cluster these biases when we cluster women. And so while there's a lot of talk about recruiting women and getting women into areas that are underrepresented, I think we should have equally focus on keeping men in areas that women have entered. And I honestly think that pay equity is way up there in making that happen, personally. Yes? Mm-hmm. Yes. Yes, I have not seen data on that, but I will tell you that you're not the first person to make that observation to me this week. that as women have entered medical education, there has been a perception that is suddenly less prestigious, less valuable, undervalued. There's certainly, you are not the only person making that observation. Nora?
So I'm obviously convinced that the endocrinologists are able to think much better than I.
And you're right.
My question is, are there any data on the pay gap within endocrinology between men and female? Men and women, are we doing better?
No. Yes. Is there any data? So, props to endocrine was given, and then is there any data on the pay gap within endocrinology in terms of gender pay gap? And the only place I've seen that, because pay secrecy is one of the ways that pay gaps are propagated, which means getting pay data is difficult. But the Medscape Physician Compensation Survey, which is the largest and most established online open source of salaries, shows a pretty substantial pay gap between male and female physicians, some of which probably is explainable by some of those factors we talked about, but I would strongly suspect, like most specialties, it isn't entirely. Yes, Christy? I do, because that'll stall in answering it. So Christy asked if I had 10 minutes to talk to a department chair candidate, what would I tell them? And I think I would have to turn this into my elevator pitch, which would be I'd have to do in less than 50 minutes. And I haven't given, I put all my thoughts into figuring out how to say this clearly in 50 minutes for the last several months. But I will work on that, because I think this is I try to be data driven in this. I think the data is where it's at, and I think that getting sort of overcome with how we feel about it, is totally understandable, and I do that too. I think that really the data is pretty convincing, and I would try to distill.
Any other questions? Thank you.
Thank you all.